Hello, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about precision medicine and Alzheimer's disease. What does it all mean, and what are key prevention strategies through tracking our own health? No better person to talk about this subject than Dr. Howard Fillit. He is the co-founder and chief scientific officer at the Alzheimer's ADDF, which is otherwise known as the Alzheimer's Disease Discovery Fund. Welcome, and really good to see you, Dr. Fillit.
Yeah, thanks for having me. Actually, if I may say so, it's the Alzheimer's Drug Discovery Fund.
Oh, what did I say? Alzheimer's
No, I
disease.
said it wrong. It's the Alzheimer's Drug Discovery Foundation.
Foundation. I'm so sorry.
That's okay.
You know what? This week, in the last week, this is the second time in a row I've done that with somebody's either name or title, but
no problem.
Correcting me, and I apologize.
No problem.
So, okay, let's start first with just a lot of people, precision medicine is a term we're hearing more often and more frequently, but let's just start from the very beginning. What exactly is precision medicine?
Well, precision medicine is the ability to use biomarkers like blood tests or spinal fluid tests or neuroimaging, brain scans, digital tests, eye tests, to define the diagnosis that a person has and to identify a drug target that can be treatable using the biomarker and seeing if it's going in the right direction. So, for example, a person comes in and they have a family history of heart disease where their father died of a heart attack or whatever. So the doctor's going to do a cholesterol. And if it's high, they're going to put the person on a statin and then use that blood test to make sure the drug is at the right dose to drive the blood cholesterol or the LDL down to where we want it to be to prevent a heart attack.
Actually, that's a good place to start. Let's start with comorbidities. Okay, comorbidities meaning certain health conditions that actually elevate your susceptibility to diseases like Alzheimer's disease.
Right.
So, we're talking about the heart, and if you have a heart problem, or with a cholesterol problem for that matter, how would one, when we're thinking about a prevention, how does one monitor to reduce that risk? So let's just take the heart to start with, because I know heart and brain are so closely related. From the patient's perspective or from people's perspective who are worried, maybe they have a familial link to Alzheimer's disease, what do we need to monitor to really minimize that, threat of having a higher predisposition?
Right. Well, there's a few ways to look at it. There's genetics. There's genetic risk factors like apolipoprotein E, particularly apolipoprotein E4, which increases if you have one copy of it from a parent, you have about a 5 times increased risk of Alzheimer's disease. And if you have 2 copies, one from mom and one from dad, and so you're a double 4, then your risk of getting Alzheimer's is about 10, 15 times the average person. So that can be done, at any time in life. The other way to look at it is if people have diabetes or hypertension. These are also 2 risk factors for cognitive decline with aging and Alzheimer's disease. And so we want to manage those diseases as, pretty aggressively as a way of prevention to delay the onset, basically to delay the onset of cognitive impairment. So that's the second one, which is these managing comorbidities, as you mentioned, Deborah. And the third one is that we actually now, with the big breakthrough now, is that we have blood tests and certainly brain scans that can tell us in life, sort of like the cholesterol of Alzheimer's disease, except for Alzheimer's, we call it beta amyloid, which is this protein that gets deposited in the brains and the plaques of people with Alzheimer's, and is thought to be neurotoxic and killing brain cells and disconnecting circuits in the brain. So we have a way of, we know that the disease actually starts about 20 years before people get symptoms, just like a person can have a high cholesterol and start developing plaques in their coronary arteries when they're teenagers, but they don't get that first heart attack till they're 50 or 60 to 70. It's the same thing in Alzheimer's. We can we've been able to detect the onset of the plaques and tangles, which would be the beginning of the pathology of the disease, 20 years before people get symptoms. So that gives us a big window for prevention. And that's what's happening.
Yeah, I mean, I guess and I'm, admittedly, I've talked about this topic a lot and I'm still not 100% clear. So, I mean, presumably a person will want to minimize their chance of even getting plaque to begin with, right? So, how much does actually cholesterol, like we know LDL is the bad cholesterol, but how much does that correlate into vascular problems that could lead to plaque in the brain? I mean, is there any way to do, I'm talking about actually starting earlier with precision medicine so that, monitoring things for health to actually prevent me from getting plaque in the first place. Do we know enough there?
That, to my knowledge, that hasn't been shown yet, that we can delay the deposition of plaques. What's going on now is we have these new drugs that actually remove the plaques from the brain. It's really incredible. You do a brain scan, you see all these plaques on the PET scan, and then you give people these two new drugs that are on the market, Leqembi and Kisunla. And depends on the person, but by 18 months, about 80% of people have their brains completely cleared of amyloid. Now that's in people that have symptoms from the disease. So they really have the symptomatic disease, not just the pathology. And it's when you do that, when you remove the plaques in that setting, and people who are already diagnosed with mild cognitive impairment or mild dementia, you can slow it down by about 30-35%. Going to prevention, the way those studies are being designed is screening people in the community, initially with brain scanning that was done, but it's very expensive and time consuming. Now we could screen people with blood tests in the community, which is really a revolution in how we can do prevention, because these blood tests are much less expensive and much less invasive. So you screen people in the community to see if they have an elevated, what's called p-tau, phospho-tau 217, for example. And if they do, then that means that they're cooking the disease, but they don't have symptoms. Confirm that with a brain scan, then put them on these drugs that remove the plaques in the preclinical stage of the disease, and see if you can delay the onset of symptoms in that context. So that's kind of how the clinical prevention trials are being designed. And it's
Right.
doable and they're being done. So it's really an exciting time because we can combine lifestyle management with drug treatment in the same way we do in heart disease. We combine lifestyle management, comorbidity management, and add a statin to the process. So we're funding a big clinical trial out of the Imperial College of London, the Karolinska Institute, called Finger Study. And it has 5 major outputs: exercise, socialization, cognitive stimulation, management of diabetes and hypertension. And Dr. Kivipelto, who started this whole finger thing, she's shown that if you manage those 5 risk factors, you can delay the onset or slow the rate of cognitive decline in aging people and in people with mild cognitive impairment. We're adding to that in Finger 2.0. By the way, Finger is being replicated in about 62 countries around the world. So it's a very powerful prevention model. But in Finger 2.0, we're doing the 5 fingers, plus we're adding metformin, which is the leading anti-aging drug, and also has been shown to have some effect in people with MC, mild cognitive impairment already. There's a big clinical trial going on. So we're starting to get into that era where we're combining lifestyle management with drug treatment to delay the onset of symptoms from Alzheimer's. And what's an achievable goal is a study modeled what it would be like if we could delay the onset of symptoms from Alzheimer's disease by just 5 years. And if we did that, we'd reduce the number of cases of Alzheimer's by 50%.
Which is a staggering number if you think about it. And I mean, like in the US alone, but then if you apply that worldwide, that's just a huge number, right? So
yeah, I mean, and the way I look at it is it makes sense because the average age of onset of dementia or symptoms from Alzheimer's is about 75. And let's say arguably the average age of death is about 80. So if you could delay the onset of symptoms by 5 years, people could have the benefit, quality of life, and maybe die of a heart attack in the middle of the night and go on, peacefully into the next whatever it is.
Yeah.
So that's why I think it's a very doable goal to be able to reduce the number of cases by 50% through prevention.
Okay, well, we'll talk a little bit more about lifestyle in a second, but I do want to go back to the monoclonal antibody therapies that are, like you mentioned, and our audience probably knows of the two, Leqembi and Kisunla, that are currently available and approved by the FDA. Now, just to be super clear, because we talk about this a lot within our community, we have people who have taken those drugs in our community. They've been on, unfortunately, some have progressed, some haven't, but how much do we know at this point? Because what I've been told is a lot more people have to go on them till we understand how significantly this will slow the disease down. It's obviously not a silver bullet. We know taking away all the plaque doesn't necessarily mean the person eventually, right? Like, what do we know exactly about that? And what more do we need to find out? Like, how many more people need to go on these drugs before we have conclusive evidence of the role that the monoclonal antibodies that are currently on market play in the entire puzzle?
Well, I think we already have the answer to that, quite frankly. There's been, a few thousand people that have been tested in clinical trials. So I think from the data from those studies are pretty clear, actually, that there's about a 35% slowing of the rate of cognitive decline. In the case of Kisunla, there was about a 45% slowing in the rate of functional decline. Now, we usually consider something, a drug, clinically significant, clinically meaningful, if the slowing of the rate of decline of a chronic disease is about 30% or better. So we're kind of in the range where these drugs have clinical efficacy. And there's other ways to analyze their efficacy. For example, if people stay in the same stage for a year, in a chronically, inevitably progressive disease, if people stay in the same place that they are, let's say mild cognitive impairment for an extra year, then we're giving people an extra year of quality of life. And I think each person has to decide for themselves whether that's meaningful. But I think most 80-year-olds, for example, would value having an extra year, recognizing their grandchildren, remember their names, being able to function independently. And I think that's kind of the difference when people take the drug in the clinical trials. The way the models show the data is that you get an extra year or so of stability before you progress to the next stage. So that means people going from mild cognitive impairment, where there's just memory loss, not a lot of functional impairment, to the next stage of the disease, which is mild dementia, where there is functional impairment and people need a lot more caregiving.
Okay, and we have a question coming in, and it was actually right on the topic. Well, let me ask the part that I wanted to ask first, and then Chris Voice has asked a question that is a good follow-up to what I'm about to ask. So what does that look like on a scan? If you're taking the amyloid, we know the monoclonal antibodies are very effective in removing the plaque, but we also know that eventually people will progress. And so does that mean they jump right to tau without amyloid present? What does that look like in a scan? And do we know that yet? And then Chris is asking, do the drugs also remove tau in the brain along with the amyloids? And what are your thoughts of these drugs helping dementias like CTE?
Well, these drugs would not treat CTE because there's no amyloid in CTA. I mean, the amyloid is characteristic of Alzheimer's disease, and it's a requirement that you have a positive amyloid scan or maybe a positive blood test for beta amyloid to get on the drugs. To get Medicare, for example, to approve the payment for these drugs, you need to make sure that it would be like treating somebody with a statin without having measured their cholesterol. So that's what the beta amyloid, after about 18 months, about 80% of people have their brains completely cleared of amyloid. And while we haven't clearly shown an effect on tau, you're right that the disease does seem to continue to progress, which is really interesting because what it does is that for many years, people were thinking that amyloid was the whole story. But it's very clear that while amyloid plays a role in the story, the plaques and so on, it's not the whole answer. And there's other mechanisms going on. And that's what's exciting about today's research endeavors, because it's becoming clear that we're going to need combination therapy. We're going to need precision medicine with combination therapy. So it used to be 5, 6, 7 years ago that 75% of the drugs in development were just to try to figure out how to remove the amyloid plaques. Now, 75% of the drugs in development are not directed against the amyloid. They're directed against brain inflammation and other mechanisms that are related to the biology of aging. Because of all the risk factors for Alzheimer's disease, by far, the leading risk factor is aging. And what we haven't done is applied all the knowledge that we have about aging and what we call gerontology, the biology of aging, to the development of new drugs for Alzheimer's disease. People do go on to progress even when their brains are cleared. And it's been shown that the clearance of the amyloid in the brain remains for at least 4 years before people reaccumulate the amyloid. And I've heard even much longer times when it's sort of the equivalent of being put into a remission, where you clear the amyloid from the brain that takes out that major risk factor, that major mechanism of the disease. And then you get quite a bit of time before it comes back. During that period, we could use other drugs in combination, like, as I say, anti-inflammatories, for example.
I always thought you needed amyloid to get tau. Is that not true? I guess you don't, because CTE, you just go straight to tau. So,
Or there's a lot of tauopathies. Frontotemporal dementia and all of its subgroups are basically diseases of tau in one way or another. So about half of them are tauopathies and half of them are related to other proteins. But yeah, tangles are a critical part of the disease. And there are antibodies and drugs directed against the tangles and the tau in the cells that's aggregating and causing neuronal death and dysfunction. But as I say, we're going to have, I could imagine a day when we'll have the right biomarkers. And just like cancer patients, diabetics, hypertensives, they're on 2, 3, 4, sometimes 5 drugs at a time, because to get at killing these cancer cells, you really have to use a number of drugs. And I can imagine a day when Alzheimer patients will be on 2, 3, 4 drugs. They're already on 2 drugs. If they're taking the monoclonal antibodies and they're on donepezil or one of the cholinesterase inhibitors, then they're on 2 drugs. And if they get put on memantine, that's a 3rd drug we use in combination. There are combination products already on the market. We're about somewhere between 20 and 50 years behind cancer, but we're catching up. And that's why combination therapy and precision medicine is so exciting right now.
but there's no, I mean, I know there's drugs for tau being tested, but there's nothing, I mean, how close are we to getting a tau monoclonal antibody for tau?
Yeah, or an antisense nucleotide or whatever. Yeah, it's not proven yet. That none of the anti-tau antibodies, to my knowledge, have really proven efficacious in slowing the disease, and some of them have been pulled from their development. So I think the whole issue with tau right now is we don't really know if attacking tau is going to have a therapeutic benefit or not.
So you mentioned the cholinesterase inhibitors. I'm curious about that because, okay, we're talking about, just to be super clear for our audience, we're talking about the early stages, right? I mean, you wouldn't be on Aricept in a later stage of Alzheimer's, I believe. Is that correct or not?
That's not true. Aricept, I mean, not Aricept, but
Exelon or
the cholinesterase inhibitors, as you said, those are the brands. They all work pretty much the same way to improve cognition and function. And they like a few of them are actually indicated by the FDA for moderate to severe dementia. So, there's a lot of nihilism about treating people in those stages of the disease, but those drugs in combination with memantine, which has a different mechanism of action, actually have been shown to have benefit in improving cognition and function in people with moderate to severe dementia. So it's out there, it's FDA approved, there's studies of combination therapy, but there's also a lot of nihilism among families and doctors about, the effect is not so robust and observable that they want to treat those people. There's a question around what kind of quality of life are we improving by giving people in the advanced stages of the disease these drugs. I think that's kind of in the back of the mind of a lot of prescribers is, why am I doing this? And it's an ethical dilemma that I think is rightfully brought up in thinking about treatment of patients with moderate to severe dementia. And it's this thing about shared decision making with families. Are we going to treat this person? What are their advance directives? How aggressive? Do the families want us to treat the patient who's not competent to make decisions for themselves anymore? So it's that goes into the realm more of the practice of medicine and the practice of dementia care more than, what's been shown in the science, I would say.
Okay, so let's reimagine. Now you've mentioned new technologies like blood tests, which we know, are becoming more commonly used, not only for trials, but in certain diagnostic practices. Clinicians are starting to use blood tests. Not everyone, but some are. So reimagine the Alzheimer's patient journey for me. What should people do if they're just entering? Is it normal aging or something more serious? What should they be asking their doctors for at this point in time?
Well, first of all, most people with a memory complaint are going to be going to their primary care doctor. And that's very different than going to a neurology specialist. But I think the role of primary care in this setting is really to determine who needs to be referred to a specialist for further evaluation. A primary care doctor can easily do a 10-minute cognitive assessment as the first thing to see if there's really something wrong. And if there is something wrong on a brief cognitive assessment tool, which is out there all over, there's a lot of them. The most widely used ones are 10-minute exams that are highly validated for detecting cognitive impairment. And if a person has cognitive impairment, then the next question is, what's the cause of the cognitive impairment? Is it polypharmacy? Are they on too many drugs that might be causing cognitive impairment? Are they not sleeping? Are they depressed? Are they vitamin B12 deficient? Do they have thyroid disease? So there's a very simple algorithm that primary care doctors can go through to determine initially what the cause of the cognitive impairment might be. And then once it's all ruled out, then if it's none of the above, then the next question is, well, is it Alzheimer's? And how can we, in a positive way, define it? There's a revolution going on because we have blood tests now that are highly predictive of having plaques in your brain. They're predictive of a positive brain scan. They lower the cost of that element of the diagnosis from a brain scan that costs about $8,000 to a blood test that might cost $500 to $1,000 with almost similar accuracy. So the primary care doctor can use a blood test, which is part of the normal work stream of a primary care doctor. For diabetes, they're going to get a hemoglobin A1C. For cholesterol, for heart disease, they're going to get cholesterol. And now for Alzheimer's, they can order a blood test, actually a panel of blood tests. And if that's positive, then that might be the time to make the specialty referral to the neurologist for further cognitive testing. Sometimes there's unusual causes of cognitive impairment that are neurologic in nature, like hippocampal sclerosis or frontotemporal dementia. And also, it's going to be the neurologist, if the patient is going to be put on these monoclonal antibodies, it's going to be the neurologist who's been educated and practices the use of these monoclonal antibodies, because there is a very specific protocol that doctors need to apply in the treatment and management of these drugs to minimize side effects and maximize efficacy.
One thing that you brought up that we haven't really touched much on is when you said polypharmacy, and we had a question come in earlier about what types of drugs should you stay away from? Like, let's just talk about the monoclonal antibody therapies. Are there drugs that you shouldn't be taking in order to be on those drugs?
I'd say the only one is anticoagulants that I know of, because they do cause some minor, like really tiny little bleeds in the brain, probably due to the inflammation that's triggered by the monoclonals. That's how they work. That's, they're promoting inflammatory cells to come in and eat the plaques. But if that goes a little bit too much, they can cause blood vessel, they can cause a local inflammation that can lead to a little bit of a bleed. So the main, the people that have had really, really, really serious side effects from the monoclonals, and it's very rare, it's like 1% of the population that gets treated, are usually people that have been getting or are on anticoagulants, in addition to the people that are ApoE4, double ApoE4, that have a more serious side effect reaction to the drugs. So I would say if your loved one is on an anticoagulant for atrial fibrillation, let's say, and they want to go on one of the monoclonals, I'd be very careful about that patient's risk, and I'd really want
I have to ask you this from the E4 because we've been asked this question over and over again, and obviously we're not doctors, so we don't have the answer to it. But one of the questions that is asked is it worth it at this point? Let's say you are homozygous E4 with plaque conformation. Would you go on the monoclonal antibodies, or are you going to wait for something else to come because you don't have any symptoms of Alzheimer's yet? And this is like actually a repeated question we get from the very active E4 population who's actually looking to solve, right? And no symptoms. Some have plaque conformation, others don't. What is the best standard of practice for that population? Because those are the people who are actively looking for prevention strategies.
I would say that the use of the monoclonals for that prevention scenario, whether they're ApoE4 positive or not, whether they're ApoE4 carriers or not, has not been blessed by data and by the FDA as an indication. So I think given some of the risks of the monoclonals, I would want to be treating ApoE4 homozygotes who have symptoms, early symptoms, catch them as early as possible. Because the point is, not everybody with plaques and even tangles gets cognitive impairment. It's an interesting phenomenon, but it's certainly true. There are 95-year-olds that have died. They're robust, they're still working, and they go to autopsy and their brain is filled with plaques and they have no cognitive impairment. So why would I want to treat them with a drug that has potentially serious side effects? On the other hand, if they're starting, that's why doing the cognitive assessment is so important as part of the workup to see if people have symptoms. And I think if I was double E4 and I was symptomatic, then I would have this shared decision-making discussion with my doctor about the risks and benefits. And it might be a difficult decision, but it's one that individuals can make and decide what their risk-benefit ethics, let's say, are in their personal opinion, what they are. I mean, we did a study maybe 20 years ago asking people if there was a drug that could stop Alzheimer's disease in its tracks, and we know people are more afraid of Alzheimer's than they are of cancer, would they be willing to tolerate a side effect of death or major strokes? And a majority of people said that if there was a drug that could stop Alzheimer's in its tracks, they'd be willing to risk death or strokes, which tells you people are more afraid of Alzheimer's than they are cancer. You think about cancer drugs and try to put them on an equivalent basis. Cancer drugs, they might delay the time to progression of the disease by 6 months. And during that time, you're vomiting and your hair's falling out. I mean, these drugs can give you a year of stability to the next phase of the disease. And, basically what you got to do for the majority of patients is go for serial MRIs to make sure you're not getting these side effects. So, if you put it in that context, in my opinion, the drugs have a better therapeutic profile than a lot of cancer drugs.
So yeah, that is definitely a way of looking at it. I just want to shift a little bit to prevention in terms of lifestyle and health a little. And I want to know what your views are on glucose metabolism, because we know that glucose metabolism does play a big role. That's why diabetics are at such big risk for Alzheimer's, because if you have insulin resistance, then you're more likely to develop plaques. I'm saying it in a very basic way. Is that the correct way to state it?
Well, the body is dependent on glucose for energy. Every cell in the body needs glucose, and it's true. Insulin is what helps glucose get inside the cell. The brain is about 2% of the body weight, and it consumes at any moment 20% of the body's energy through glucose. If somebody is diabetic and they take too much insulin, and their glucose level drops below about 60 in the blood, the first thing that happens almost immediately is they go unconscious. And then you give them glucose and they wake up, let them suck on a candy or whatever, pour some orange juice down their throat. They wake up. That's how dependent the brain is acutely on the availability of glucose for energy, because it's so metabolically active. If you think about that in a chronic setting of a diabetic or even a pre-diabetic, you can imagine that a subclinical level of glucose energy inefficiency would contribute to neurodegeneration. And I think that's what's so interesting about the current studies that Novo Nordisk is doing with GLP-1 agonists. Like they're studying Ozempic for semaglutide for Alzheimer's disease, because this is such a clear hypothesis, and there's preliminary data that metformin and liraglutide and other glutides are beneficial in preventing and treating, predominantly preventing as a risk factor, cognitive impairment, cognitive decline, and even Alzheimer's disease. So this is another way that the biology of aging is being translated into new therapeutics for Alzheimer's, because it's not just, as you said, the anti-inflammatories, but it's also this metabolic dysfunction that occurs with aging that predisposes people to neurodegeneration. And when there's neurodegeneration, there's plaque formation and all of that.
So should we all just be wearing a CGM, a constant glucose monitor, and stay in the band? And would that reduce our chance of getting Alzheimer's? I mean, it's not.
Yeah, but then people would die from neurosis. You know what I mean?
It's like, ask my family. I wore one for 3 months. They would agree with you. Beth is asking regarding diabetes, are type 1 diabetics at equal or greater risk as type 2? I actually always wondered that as well.
Yeah, that's a great question. Honestly, I don't know the answer to that. I think I really just don't know. I have to admit, I'll have to look that one up. I don't know.
But we know both are at risk. We just don't know which one's higher, right?
Yeah, I would think type 1 diabetics, because it's so much harder to control. People have to take the right insulin and everything. But I've never seen that study done or anything like that. So it's something to look up, and I'll have to try to figure it out.
Okay, we'll get back to you, Beth. Good question. Okay, so tell me about 10 years from now. What is your prediction about where we're going to be, and what's going to be a checkup for Alzheimer? What's it going to be like? Like, let's say I mean, by then in 10 years, I might be towards that age where I'm thinking more about, is it normal aging or something more serious? What should I ask my doctor? What do you think is going to be available to people, and what should they have in mind for kind of like a prevention strategy if you can't rely 100% on your GP because maybe he's not an Alzheimer's specialist? What should the population be asking, and how's that going to change in 10 years?
Well, there's been a revolution in Alzheimer's diagnostics and treatment. I mean, we have the first disease-modifying drugs on the market in the history of the world. We have a simple blood test that can tell you with about 90% certainty if you have Alzheimer's disease. I mean, this is really a revolution. And as doctors become more familiar with these tests and the drugs, I think it's going to become more commonplace for primary care doctors. When I trained, I never heard the word Alzheimer's disease. I've been doing this 45 years. When I trained, Alzheimer's, I'd meet somebody at a cocktail party, they'd say, "What do you do?" I'd say, "Well, I do research on Alzheimer's and I take care of people." They'd look at me cross-eyed and say, "Alzheimer's, I never heard of it. Never heard of it. It wasn't in my textbooks." So I'm just trying to say we've come so far. And in 10 years, I think we're going to be so rapidly changing the world. It's not just going to be blood tests for amyloid. There already are blood tests for tau. There'll be imaging tests for tau. We're going to be able to make a precise diagnosis. We'll have blood tests for the right inflammation to see if inflammation is contributing to that person's dementia or cognitive impairment. We'll use these metabolic tests, and we'll be looking at other pathways, which I won't go into. So you get a profile like you would in cancer, and then we'll tailor the drugs to your biomarker profile, your blood test profile. And I think that's going to really have a big impact on not only prevention, but treatment of the disease.
But the blood test can really pick it up very early, right? Before you're symptomatic. Can it pick up?
Right, but that's prevention. That's what we want to do, right? We want to pick it up. So maybe, when you turn 65, you'll get screening for cognitive impairment. And if you're positive, you'll get a blood test to see if you have Alzheimer's. Right now, there's the Medicare mandates that during the wellness visit, the annual wellness visit that people with Medicare are supposed to get, that there be a cognitive test.
Yeah.
See if they're like,
good luck. Sorry. Good luck getting that. I've asked for a baseline and I got laughed at. So
right.
It's hard.
But I think the world is really changing with this whole thing. I mean, honestly, when I went to med school, Alzheimer's disease was not in my textbooks. I never heard of it for like 10 years after I graduated. And then I learned my first. The world is changing rapidly. This is becoming a mainstream illness for neurologists and other doctors. Everybody's heard of it. Everybody's scared of it. And we have treatments now and ways to get a definitive diagnosis that's non-invasive. It's a completely different world. In 10 years from now, it's just going to be, we're going to have multimodal treatments, diagnostics. And I do think that the number that we're going to conquer this disease, not completely, like all the diseases, chronic diseases of aging and old age, we're going to be able to treat and manage it in a pretty good way. But will we be able to cure it completely? I don't know about that so much, but certainly we'll be able, the same way that we've come to see cancer as a death warrant, to now this is a chronic disease that we manage through precision medicine. And that's what's going to happen with Alzheimer's and related dementias.
All right. Well, thank you so much, Dr. Howard Fillit, for your time and explanation. I learned a lot as well, and I'm sure it's very helpful to our community. Dr. Howard Fillit, I'm going to say it right, the Alzheimer's Drug Discovery Foundation.
Thank you.
Thank you so much for joining us. If anyone missed any of this interview, don't forget to sign up for our newsletter on beingpatient.com, where we will post the entire interview on our website. So thanks everyone for watching, and thank you, Dr. Fillit. We really
Thank you.